Welcome to Health Reform 2.0, the only place on the internet for people with a curious mind and a desire for a better healthcare system. Here we take you on a journey of our current quagmire, tell you where it came from and why the government can't fix it. Along the way, we'll tell you some history, bust a few big myths, tell you a few stories, and give you an idea how we can work together and get the healthcare system we want. Let's get started.
Well, ladies and gentlemen, at the end of the last episode, we started to talk to you about EMTALA, the Emergency Medical Treatment and Labor Act. And we spoke a little bit about what it is, when it was created, and what it does in terms of how it requires hospitals to treat patients. We started to propose some ideas that are out there with others about getting rid of it, with the potential benefits of getting rid of EMTALA, as well as some of the benefits of having EMTALA. And after that, we're going to talk to you a little bit about how hospitals are hostile to other hospitals. And then we're going to talk about how insurers are hostile to everybody. With that in mind, I want to welcome Tim Henning, my partner in crime with this series. And Tim, why don't you bring people up to speed on EMTALA and how EMTALA came to be, and then let's talk a little bit about some of the statistics about where it is today and what people think about it.
Sure. I'm not an expert in this matter. I dealt with it quite a bit when I was running some IDN business with large hospital systems. And we actually had a consulting company that really helped understand and improve emergency department functions. Emergency departments are, in general, run pretty poorly when it comes to standard, patients that show up for things that aren't critical. They do a massively good job, as you know, in critical access trauma cases. Right. But in some cases, they're overutilized for trivial things that, quite honestly, you should be just going to either take an aspirin or go to see your regular doctor.
Yeah, many of the reasons people are going to hospitals is because then they don't have any money to pay. The hospital has to take them and see them. They go in for colds, they go in for bruises, they go in for all kinds of things that are not critical care. And the biggest issue is for many of the things people go to the hospital that are not trauma related, there's nothing the doctor's going to do. There is no cure for the common cold. There is not really much of a treatment they can prescribe at a hospital for the flu. So a lot of the things they're saying at the hospital are not always critical care.
So what was happening in the past before this law was initiated was some violations where people were either being turned away or not treated properly or not screened properly and so forth. So the law was passed that really stipulates that any emergency department is required to screen every patient that seeks emergency care, to stabilize, and then to transfer those regardless of their insurance status or ability to pay. So this law was passed in 1986 and has been in effect ever since. There's been some modifications along the way, but in general, it was a safety gap to keep patients from being thrown out of the ED or not taken care of in the ED or not screened, regardless of their ability to pay or not. Now, don't think for a minute when you show up at the emergency department, the first thing they ask for is,
do you have insurance?
Exactly. And if the answer is no, you're going to be taken off to, if you're not critical or, in a situation that requires an immediate attention, you're going to be taken off to a little booth somewhere where a special person will come out that deals with this. And you'll spend a long time in there dealing with the paperwork and all the stuff. And if you do have insurance, by the way, the same thing happens. It just takes 20 minutes to 40 minutes and versus the 2 hours it's going to take if you don't have insurance.
And don't forget that if you walk in the hospital today and the hospital treats you because they have to by law and you can't pay, don't think for a minute the hospital doesn't have some recourse, number one, to go after you. But number two is if they can't get it collected, they do get reimbursement through Medicare from the federal government. So it isn't dollar for dollar billed, but as we've said to you many times in the past, The dollar for dollar is not what's being paid. It's 20 cents on the dollar on average. So they get reimbursed pretty well for those patients compared to what their normal reimbursement rate is.
They do, and that's going to show up in what is considered the community service aspect of their P&L, where they show that amount of money that they basically give away. They don't give it away.
And as we said to you in the last episode, there's a whole lot of hospitals that today are just violating EMTALA and throwing patients out the door, letting them out on the street, transferring them to other hospitals because they're not getting reimbursed adequately for even insurance-covered patients for many of the critical care items that they're coming in with. So hospitals are starting to be very good at selecting the patient mix that's coming in the door. And when they see a disease state that's not going to give them a good reimbursement, some of the hospitals out there now are rejecting those patients one way or another. So, Tim, we've got some statistics on violations. You want to go into that?
Yeah, I will. I want to reiterate one point. It comes down to not only the reimbursement for the disease state. Hospitals reserve beds for specific illnesses and issues that pay a very high rate. And if they have a bed set aside for something that's going to have a higher rate of reimbursement, and you come in with, let's say, pneumonia, you're not going to get that bed. I can give you a case that happened in the Pacific Northwest where a woman was turned away. She had pneumonia. She died 2 days later. And that institution is paying dearly for that mistake. I'll give you another one where the same institution transferred a patient to Harborview who died on the way in the ambulance because they hadn't stabilized the individual or screened them prior to sticking them in the ambulance to move them over to Harborview. And Harborview is a trauma center in Seattle, as you probably know.
Yep. So, let me pick up on that because if you take a look at the examples that Tim just gave you, let me give you some larger statistics. 30% of hospitals in the United States have violated EMTALA. A recent investigation, reporters found that 4,341 EMTALA violations occurred at 1,682 hospitals nationwide between 2008 and 2018. EMTALA violations more often at hospitals with fewer than 100 beds, and these hospitals are accounting for about 34% of violations. And I'm not going to read through all of them. I'll put them up on the screen. But the last one's important to look at. Between 2016 and 2018, EMTALA violations were linked to at least 34 patient deaths. 34 patient deaths. And, the law was passed for some good reasons, but it has started to cause lots of problems. And we should talk a little bit now about ideas for solutions. As we said in the last episode, there's a group of people out there that think that we should repeal EMTALA and just get rid of it and not make it required for a hospital to treat you. So if you show up at the hospital door, they can either refuse you, or they can choose to treat you. But if they do choose to treat you, it'll come out of a charity care category. It won't come out of some reimbursed federal program. And many people think that's a superior solution. What do you think?
I don't think it's a good solution either way, because at the end of the day, you're still going to get the care. You don't have the money. Somebody's going to pay for it. And it doesn't matter if it comes from this bucket or this bucket. You know where it comes from, right? It comes from the taxpayer.
Right. So what's necessary, I think, is to redesign the system, come up with a new way to deal with these patients. And part of what we've put together in the Health Reform 2.0 package is a method to redesign the healthcare system so we can eliminate this. We can eliminate it in its entirety. Now, we'll do a future episode to go into more detail about this. But in effect, what happens is under the current system, if you don't have insurance and you show up at the hospital, there's nothing that they can do. They have to take you. The expenses get spread out. And believe me, this is not a cheap system. In our system, everybody gets insurance. And if you show up at a hospital and you don't have insurance, the hospital can choose not to treat you until you sign up for the insurance plan. Okay, so you're going to sign up for an insurance plan. Oh, I'm going to incur all these costs that I can't afford. No. If you truly can't afford the cost, the government is going to loan you the money to make the premium payment to the point that your income is such that you can pay that money back to the government and pay for the premium yourself. It takes the burden of you off the public dole. It makes you responsible for your care, but it also gives you an avenue to get that care and get financial support to take care of it. The second thing it makes hospitals become more accountable. Then, when they're taking in these patients that they know they're not going to get paid for, they're not going to take a patient that's healthy and be as likely to run them through every single possible test they can run to build up the bill so they can make enough money to offset the patients they're not getting paid for. So the downside of EMTALA picks up on some of those things. Number one is hospitals now have to go make money in all these other categories because the cost of these patients has been shifted over to the hospital. Medicare and Medicaid have been cost shifting for years, lowering reimbursement rates to hospitals and doctors, and for doctors to treat those patients. Where do they go to get that money that they're losing?
It goes right back to where we always said it goes back to. It goes back to CMS and back to the taxpayer.
Exactly. And if you're an insured patient, it goes back into higher insurance rates because the hospitals are negotiating higher rates from the insurance companies because if they don't get enough money to offset the losses on Medicare and Medicaid. So EMTALA sounded like a good idea, particularly if we were doing it from the heart and we wanted to take care of all these people.
Yeah.
But the reality is, it hasn't really taken care of these people any better than they were being taken care of before. And it's put us in a position where it is singularly in the system driven up the cost of care for the rest of us significantly and taken everybody out of the loop in being responsible for their own care and their own expenses. So if we want to start to solve our healthcare crisis, we need to start to get people to pick up their own responsibilities. We still have to have a safety net. We still have to do that. But we've built a safety net into Health Reform 2.0 that is part of an innate system that makes the safety net not extra costly and also coordinates that across everything else. So there's less duplicated services and less fraud and abuse.
So what happened to emergency room visits after the Affordable Care Act was passed?
They've gone up.
Absolutely. Because it's an easier place to go. I've said all along, we've always had a national health care plan. It's called the Emergency Department.
Yeah.
And so with this, if you go in there and get treated, you don't have insurance, they will send their bill collectors after you. But hey, if you can't pay, you can't pay. And it ends up going back to what you described as far as where the reimbursement comes from.
Exactly.
So there's one more thing I want to say on EDs before we move on to our next topic. And we're going to get into it in an episode we're going to do here shortly called the in-network versus out-of-network. When you go into the emergency department, you got to be really careful because many times the people that are treating you, the doctors, the anesthesiologists, are not in-network and you don't know it. An example was the ambulance transfer
that I went through, yeah. So we'll get $9,000 bill versus a $2,600 bill.
We're going to get into that whole ED thing and part of our in-network versus out-of-network episode coming up.
You've been listening to Health Reform 2.0 with your hosts Tom Locher and Tim Henning. We hope you found the topics interesting, that we answered a few questions, that you laughed a bit and were entertained. Please feel free to invite your friends to join the discussion, and remember, hit that like button and don't forget to subscribe. Send us your questions to info@hr-20.com. We hope to see you again next time.